Hello everyone, my name is Matthew Carvey, and along with the rest of the Emergency Medicine Club E-Board of Fall 2019, we'd like to welcome you to the Emergency Airway Management Workshop. So it's going to be a one of two-part series. Paul Fallu is going to be doing the practical portion where you're going to watch him demonstrate each airway skill. Here's our objectives. Just a little bit of basic anatomy before we move on. When you open up the mouth, you can see that at the top of the mouth, you're going to have the hard palate running posteriorly to meet the soft palate, and then they both run inferiorly to meet the laryngeal pharynx, and then there's a split just inferior to that leads to a posteriorly running esophagus and an anterior running trachea. And blocking that trachea is going to be our epiglottis, and that's going to be one of our targets to kind of aim for that placement of the tube. Once you get that out of the way, that opens up into the laryngeal opening, and then you can place your tube through that. Here's our oropharynx. The uvula, on the right-hand side image, is one of our predictors of how difficult the airway is going to be. So if you can see the uvula in someone who's opened up their mouth, that's kind of a predictor that, okay, this might be a little bit of an easier intubation, as we'll talk about in the Mallampati score a little bit further on. A little bit further down now, we can see that we have the actual laryngeal opening now, and then the epiglottis is just, just anterior to the vocal opening there. So that's going to be our real target. So once we move that epiglottis out of the way, which is at the top part of that image, then we can see that we have our entrance to the trachea right there, and that's where we're going to place our tube. So that's our kind of our gold standard image that we want to see when we're opening up the when we're opening up the larynx. Even further down now, so now we're into the actual trachea. We can see on the right-hand side the carina kind of splitting the two into your right main bronchus and then your left main bronchus. When we're placing a tube, it's very easy to place it into that right main stem bronchus because it kind of runs in a continuous pattern rather than an acute angle like the left main bronchus. So we really have to watch out for placing our tube too far into that right main stem bronchus because, again, then we'll only be ventilating one lung. So just withdraw that tube a little bit and ventilate both lungs. Here's our lungs, things we're hoping to ventilate, obviously. Indications for airway management. So this is a huge thing that I want you to take away from this PowerPoint presentation is the three kind of indications are can't oxygenate, can't ventilate, and predicted course. So these are all things that obviously the patient can't maintain their own airway anymore. So now we have to maintain it for them. So we either can't get enough oxygen into them, we can't actually properly ventilate them, or we kind of predict that, okay, this patient's going to go downhill quick, so let's just throw a tube in. And then we can also put surgery in there as well. If we have a predicted course of we're going to do surgery, we're going to be blocking the trachea, we want to make sure that we can ventilate this patient properly before we move on with that. More indications for airway management, so there's kind of two big ones right here, I guess four big ones, but we can see the combative patient right there. We want to make sure that we maintain an airway in that patient because if they go downhill, we want to make sure that it's in and they're properly sedated, they're properly whatever you need to do to get an airway management on that patient because they are not going to be able to maintain it by themselves. And then surgical intervention as well. You can see the knife sticking out of this guy's neck. This is obviously an airway blockage, so we need to make sure that we maintain patency of the airway in them, either by doing, in this case, most likely a crike. A little bit further down, we could also do a trach on them, and then just making sure that we maintain the airway. So the three simple indications for airway management were can't oxygenate, can't ventilate, and predicted course. Try and drill that into your memory. We're going to run into our ABCs now. So everyone's taking first aid here, CPR, remembering our ABCs. So airway is going to be an initial airway management that we do. So we're going to look at the patient. Are they cyanotic? Can we hear any sounds coming from the mouth, some like stridor or wheezes or anything? When we look at this patient, are there any anatomical defects? We can see in Pierre Robin that the chin is actually pushed way far back. And what that's going to do is that's going to make your intubation a lot harder because you're not going to be able to visualize the airway as easy. Moving on to breathing, so we're going to take the rate, rhythm, quality of our patient's breathing, any chest wall movement. We're going to auscultate, palpate, and percuss as well. And that's just to determine how well this patient is actually breathing. Is there any kind of consolidation? Do we hear anything when we listen to the chest? Things like that. Circulation, we can also see how this patient is actually doing by just looking at their hands and seeing if there's any peripheral cyanosis, and then taking a capillary refill as well. And that's going to determine how well our blood flow is to the extremities. It's going to determine if we're in shock at this time, because we're going to have shunting of the blood to the core to maintain obviously all of the vital organs. In your history as well, you're going to learn this as you move on with term 4 and term 5, and it's just various techniques to see what kind of led to this state the patient's in. Was it from travel? Was it from the flu? Was it from any type of viral, bacterial, whatever kind of infection? Anything can cause an airway compromise. We need to determine how that actually led to the current state of the patient to try and reverse what's going on. It's just an airway algorithm that we use in the flight environment. So we start out with an unconscious, unresponsive patient. If they are, then we can do something called a crash airway algorithm, which is basically just run right into intubation. Don't need to RSI an unconscious, unresponsive patient who's dead, because they're not going to have a gag reflex. And then if they are going to have predicted difficult airway as well, then we need to have other things in place to try and reverse possibly missing an intubation in this patient. And then if all of that fails, then you move into the failed airway algorithm, which usually leads to a crike. What we're going to start with basic life support is positioning of the patient. And what we're trying to do in this case is we're trying to align the axes. And when we align the axes, we're trying to line up basically the tragus of the ear with the sternum of the chest. And that just gives you the best image when you're trying to either visualize the tracheal opening, or if you're trying to just get the patient to breathe a little bit easier. So we do a head tilt chin lift, which everyone knows what that is from CPR. And then the jaw thrust is going to be grabbing the posterior portion or the angle of the mandible and then pushing it anteriorly. And again, that's just going to displace the tongue, which is the #1 cause of any obstruction. That's the reason why we're going to place an OPA. It's the reason why we're placing an NPA, is to try and bypass that tongue, which is the obstruction. Here's kind of the devices we're going to see when we're in the hands-on portion. So wall-mounted O2, that's where you can connect your devices to. Non-rebreather, that's kind of the device that we use when the patient isn't breathing so well. So we want to try and get a little bit more oxygen into this patient, 90% to 100% O2, to try and raise their saturations. Nasal cannula, everyone's seen a nasal cannula on a patient before. It's kind of just passive oxygenation, or we can give them pre-oxygenation prior to an RSI, rapid sequence intubation, or intubation, just to try and provide a little bit more positive end expiratory pressure. And then the nebulizer is going to be delivering obviously nebulized medications such as albuterol or ipratropium bromide. So OPAs and NPAs, so you're going to be placing these when you're in the hands-on portion. So sizing and then placement is a really important thing. So OPAs, starting with those oropharyngeal airways, what we're going to be doing with this patient to measure how we want to place it is we take the one end of it, like, as you can see in the image, and you place it near the lips, and then you measure it until the angle of the mandible. And when you have that properly sized OPA, that's when you know you can move on and place it. Placing it, you're going to insert it backwards first, running along the hard and soft palate, and then you're going to flip it 180 at the back of the oropharynx, and that's how you're going to place an OPA in an adult. And then NPAs, you can see it's going to be measured from the tip of the nose to the tragus of the ear, and that's a properly sized NPA. And those go in one or both nares, and you need lots of lube for these ones because it's going to be a very painful procedure for the patient. So again, here's more things on placement. We can see on the left-hand image that they're inserting it backwards first, and then they're flipping it 180 to get it placed into the back of the oropharynx. And then the NPA, you can see, is placed, and it's displacing, not displacing the tongue, but it's running posterior to the tongue and just bypassing it. So we can place both OPA and NPAs in patients to try and open up that airway even more. So contraindications to OPAs, biggest contraindication is a gag reflex. If they're choking when you're placing an OPA, please don't place the OPA because they will vomit on you. That's not a good thing. And then NPAs, kind of your relative contraindication is going to be a basal skull fracture. Basal skull fracture is that posterior fracture at the very posterior end of the nasopharynx. And the problem with this is if you're placing a nasopharynx, not so much a nasopharynx, but a nasogastric tube is definitely a contraindication for this, because if you place the nasogastric tube, which is a really long, basically wire-like device, you can see how it might coil up in the brain. The NPA is not so much, but you could cause a further damage to that skull fracture by placing it and trying to make it worse. So just trying to familiarize yourself with how you insert the OPA in the NPAs, because you will be doing this and expected to know how to do this when you get into the hands-on portion. Bag valve mask, we've all played around with one of these before. So you have the one-handed and two-handed techniques. One-handed technique, and you'll be using the C and E technique. C wraps around the mask itself, and then the three fingers kind of grab onto the mandible, and that's just to create an adequate seal, because we don't want oxygen leaking around the mask itself, because then that's oxygen that's not getting to the patient. Two-handed technique, again, that's just making it easier and a lot harder for the air to escape around the mask itself, and more going to the patient. So it takes two providers to do two-handed technique, which is one of the kind of downfalls to it. Going to deliver 12 to 16 breaths per minute in your standard patient, and you're going to deliver that breath over 1 second. So not just rapidly giving it, but over 1 second. And then please, please, please do not deliver the entire bag's volume to the patient. There's about 1.5 liters in that bag, and the average tidal volume for our patients is 500. So if you're delivering 1,500 mils to this patient, you can see how that would lead to some type of lung damage at some point, either causing a pneumothorax or something, obviously in this case. Suctioning, just a good thing to have when you're planning on intubating a patient or any type of fluids that are building up in the mouth. It's just good to have suction just right beside you. No matter how hard the intubation is, if you kind of predict, okay, it's going to be real easy, it's still nice to have suction. Two types of suction. You're going to be the Yonker suction at the top, which is basically going to kind of give you that posterior oropharynx suctioning. It can go a little bit deeper than that, but it's not recommended. And then you have your inline suction, which is going to be placed down a tracheal tube or an ET tube, and that's going to give you further kind of suctioning past the trachea itself to withdraw mucus plugs or any blood or anything that's building up in that area, because you don't want that stuff going into the trachea. King LT airways, these are our supraglottic or rescue airways. So we can see in our image that this is basically just, you just deflate the King LT itself, and you just shove it into the mouth, to tell you the truth. Make sure you get the tongue out of the way and just really just jam it in there. And the first bubble we can see is blowing up inside the esophagus itself, and that's going to cut off any type of airflow to the esophagus. And then the second bubble is blowing up in the laryngopharynx, and that's going to block any airflow from escaping out the mouth. And we can see the only place the air is going to go now in between those two bubbles, it has to go into the trachea now. And that's the advantage of these, is it's a quick device that's going to give you maximum airway delivery. And then we can think about further things that we can do for this patient. This isn't a long-term fix, but it's something that you can do in the meantime to try and get airway delivery to this patient. There's a lot of information on this slide. Just the main thing I want you to take away is just the sizing of the tubes and end tidal CO2. So the sizing, you can see, is based on height itself, 4 to 5, 5 to 6, and greater than 6 feet. And you're going to have those kind of 3 different colored King LTs, and you'll see those in the hands-on portion as well. End tidal CO2 is something very, very, very important for airway kind of stabilization and determining that we're actually in the trachea with our devices. And end tidal CO2 is something you can hook up to the end of a tracheal tube or a King LT, and it tells you, gives you a waveform, and it gives you a number, and it tells you if you're actually in the trachea. So if we can see a proper square waveform, which we'll see in a bit, then it means that we're in the trachea, rather than a flat line on the end tidal CO2, and then you're placed in the stomach. The stomach doesn't have any CO2, so you can't pick anything up. All right, moving on to advanced life support. So advanced life support, we kind of follow the 7 Ps when we're doing advanced life support. It's just a method I use, and it's always been the easiest for me. This isn't something you have to memorize at all by right now, but when you move on to clinicals, this is going to be something very easy for you to kind of just get in your head. And then when you're doing an intubation, you'll have all of the preparation you'll need to successfully place an airway. So by all means, you don't have to memorize this right now, but it's good to know. So preparation using the lemon sodas technique is the first P. So we're going to run in through this in the next slides here. So looking at your patient, this is going to be a difficult intubation because they have no neck. And what that's going to lead to is all of this adipose tissue that's developing around it itself. When you're placing that airway, all that adipose tissue is going to be pushing everything posteriorly. And so when you're opening up that larynx and looking for that tracheal opening, it's going to be very, very, very hard to visualize that in this patient. So looking at them and kind of just predicting how hard the airway is going to be. The E is going to be the evaluate, and that's going to be using the 3-3-2 rule. So the first 3 is going to be, can you stick 3 fingers in the mouth? If you can, perfect. And then the next 3 is going to be measuring from the kind of the bottom of the chin to the hyoid bone itself at the very posterior end of the kind of chin. And if you can place 3 fingers there, then that's great. And then the 2 is going to be moving from where you had that last finger placed, just at the hyoid bone, to the laryngeal prominence. And if you can place 2 fingers there, then that's great. And it's just another way of telling you, okay, this might be a little bit of an easier intubation, or this patient doesn't have any airway kind of indicators that say it's going to be difficult. Mallampati score, this is something that everyone's kind of been pushing away from now, just because when you look at a class 1, that's supposed to tell you that it's going to be an easy intubation or an easier intubation. And class 4, that's going to be a harder intubation. And the problem with this is when you tell a patient to open up their mouth, which really isn't conducive in the emergency environment because a lot of the patients are unconscious, can't open their mouths up for us, but great for the anesthetic environment. When they open up their mouth, you can see the uvula and you can kind of see that very posterior oropharynx leading into the nasopharynx. Then this is supposed to be an easier intubation. Problem is, this is also, the problem is that you can see that this is going to be also a harder intubation sometimes too. So it doesn't just say that, oh, this is going to be an easy intubation, but sometimes a class 1 can tell you that's going to be a lot harder too. So it kind of doesn't really fall in line with what we're doing in the emergency environment, but just another thing to add to kind of your toolkit. So obstructions, we can see that we have some type of vocal cord obstruction or tumor in this case, just another thing that's getting in your way to try and placing a tube through that opening there. Neck mobility is going to be a big thing. We can't properly align the axes in this patient because to align the axes, we need to either do a head tilt chin lift or we need to do a jaw thrust. So a jaw thrust will work in this case, but very difficult to do, and any lack of neck mobility, it's going to be very hard to intubate this patient. So just having any backup airways like your King LTs or anything that's going to make it easier for you to try and stabilize this patient's airway. Suctioning, as I've already said, is very important. For any type of patient you're going to intubate, it's just good to have suction right there and ready to go, just in case any type of fluid builds up or any trauma happens when you're placing that airway. Just good to have it and ready at hand. Oxygen delivery devices, so we can see our nasal cannula is going to be there. That's going to be providing pre-oxygenation in this case. And the pre-oxygenation is something that we do before we intubate the patient. We want to try and get as much oxygen delivered to this patient, getting our saturations greater, like around 99 to 100% before we take away the oxygen, because we want to make sure we have enough time to properly intubate this patient. So this is something that you can leave on the patient. You're going to start it at 5 liters per minute when you're thinking about intubating this patient and preparing, and then when you are ready to intubate the patient, you're going to blast it up to 15 liters per minute, and that's going to give you a little bit of positive end expiratory pressure to try and maintain oxygenation while you're intubating them. Bag valve mask, need that. NPAs and OPAs, just another thing to have beside you before you're intubating the patient, or if you're not going to intubate them, that's great. Just maintains the airway. And then your end-tidal CO2 devices. So we can have 2 devices that you're going to see. We can have one that hooks up directly to the tube and then connects to the monitor itself. And on the monitor, you'll see a nice square waveform if you're properly in the trachea itself. And then if you RSI this patient, rapid sequence intubation, then your end-tidal CO2 should be around 35 to 45 for a standard patient. If they're unconscious, unresponsive, and dead, then around 10 is what you're aiming for, or greater when you're doing CPR. And then the other one is going to be kind of like a litmus paper. So if you place this on the tube and you're in the trachea, then it turns gold, and gold is good. So if it remains purple, then it most likely means that you're still in the esophagus. So you need to either think about replacing that tube or just removing it and thinking about something else. And so gold is good, remember that, and that's all based on CO2 levels itself. Drawing up our drugs as well, so our analgesic, our sedative, and our paralytic, and that's just going to help us intubate this patient. If you're doing an RSI, rapid sequence intubation, or if you're doing a rapid sequence sedation, or if you're doing an awake intubation, whatever drugs you need to properly facilitate whatever kind of airway device you're going to be using, then drop those medications now. All right, having our airway equipment. So the main things we're going to need are our ET tube, and the ET tube is on the left-hand side there. We're going to grab one size above and one size below. And to measure those devices or kind of predict what we're going to use those devices for is a standard female is going to be around 6 to 7 millimeters, and that's going to be the size that you choose for them. And then for adult males, it's going to be 7 to 8. So you're going to grab, if we grabbed a 7 for our adult male, then we're going to grab a size 8 and a size 6 as well, just in case we grabbed the wrong size for this patient. We're going to test that balloon with our 10 ml syringe just to make sure that it blows up, and then we're going to keep that 10 ml syringe hooked up as well, just to try and make it easier when we do pass that tube. I'm going to choose either a Macintosh or a Miller blade. So remembering these is very paramount, especially if you're going into anesthesia or emergency medicine, because you are going to be asked which one, which one you prefer, or which one the resident prefers before they intubate. So it's good to know because you could pass it to them and get everything ready for them. So the Macintosh, easy way to remember is Mac has a C in it, and this is forming a C, and the Miller blade itself is that kind of straight one. The third letter of the Miller blade is an L, and this forms an L shape. You're going to hook these up to your disposable handle, and then you have your laryngoscope ready to go. And then we also have a bougie and stylets. So the bougie is the third one kind of on there, and that's going to go into the trachea before we actually place the tube. And that goes over, and we just place our tube over top of the bougie, and then it just makes it easier because if we have a very difficult airway or any type of airway, it's easier to place a smaller device first rather than a large one. So the bougie is smaller than the ET tube, and we can pass that tube over top of the bougie after that. You'll practice this in the lab as well. And then stylets are something that we place into the tube prior to intubation, and it just basically makes it more stiff so that when you're placing it, it doesn't fold up when you're trying to get it past that into the trachea. It makes it more malleable. You form it into, Canadians call it a hockey stick shape. For all you Americans, I'm not sure what you would call that. It's an L shape. So it just makes it more malleable, and you can shape it and try and increase your stability of the ET tube. And then grabbing lots of lube, because lube is good. And then having our backup airways as well, so our separate devices. We have our King LT, which you've already discussed. You can grab a Gale forceps if you think there's going to be an obstruction in the airway. Just you open up that airway with the laryngoscope, and you just basically grab the object and remove it. And then having our Crite kit ready as well, just in case we have a very difficult intubation and we are trying to intubate and it's not working, then we're just going to cut the neck. All right, moving on to pre-oxygenation, our second P. So pre-oxygenation, as we've already discussed, is going to be used with a nasal cannula or a bag valve mask, just on how stable is your airway now. Obviously, in the left-hand image, they're very stable, so we can place the nasal cannula on. And if they're kind of unconscious, unresponsive, and we need to place an airway ASAP, then just bag them up to 100% and continue on with your intubation via that means. You can have a nasal cannula under that bag valve mask as well, just to get more oxygen into them. Third P, pre-treatment. You're going to be giving them any medications that you think will make it easier to facilitate your intubation. So we use something called the LOAD acronym, kind of going away as well. But we used to use atropine for kind of too much buildup of mucus and all that other crap that's building up there. And then lidocaine was given for our head injury patients. Again, this is kind of moving away from this. Atropine is more or less, it's in the pediatric realm for sure, but the adult realm is kind of like, well, let's just intubate this patient, not really worry about it right now. Paralysis with induction. So another key point that I want you to take away, very, very important point, is do not paralyze your patient before you sedate them. So you're going to sedate and remove their pain prior to giving them a paralytic. So it's not fun to be paralyzed and still know what's going on. So this happens, and it happens all the time. So please make sure you give your analgesic and your sedative before you give your paralytic. We want these patients down and then paralyzed. We don't want them remembering anything, because that's how lawsuits happen. Positioning. So we've already talked about lining up the airways, and that's called the sniffing position. We're not going to do the sniffing position in any type of neck trauma because that's obviously going to make it worse. But if you do not have any signs of trauma, then you can place a pillow under the head, and what that does is it kind of facilitates that airway axis alignment for you, as we can see in that first image. And that just makes it easier for you because you open up that we open it up with the laryngoscope, and you can just basically see the laryngeal opening right there in most cases. And then if that's not working for you, what you can also do is something called the Sellex and the burp maneuver. So it's backwards, upwards, rightwards pressure. And that's going to be someone else's hand placing on the cricothyroid membrane and really just displacing that trachea posteriorly so it can push it into your view when you've opened up the mouth. And that's just to try and facilitate a little bit easier access of you placing a tube. All right, so actually placing the tube. So we're going to use our laryngoscope. We're going to open up the mouth with it. So we'll do all of this in the wet lab as well because this is easier said than done. Open up the oropharynx with the laryngoscope. You're going to visualize the vocal cords, so you can see that in the second image, and then you're going to pass your tube or your bougie, whichever one you're using. You're going to pass that, and you're going to put it in through those two vocal cords right there. And once you've placed that in there, you're in the trachea. Then what you're going to do is you're going to have your tube in there. You're not going to remove your hand off of that tube because the tube will be displaced very easily. So keep your hand on the tube near the mouth. Do not remove it. You're going to blow up the balloon with a 10 ml syringe. Okay, and everyone forgets is the 10 ml syringe, but please blow up the balloon because that's how you're going to cut off that airflow from moving backwards up into the mouth and out the, obviously out. And so once we have that, then the tube's in place and it's blown up. Put on your end-tidal CO2 device, whatever one you're using, and visualize the waveform in this case. So you can see the waveform, we'll have a better image of it, but it's a nice square waveform and that third kind of waveform on the monitor. Then you're going to use your BVM, put that on top of the end-tidal CO2, and there's your end-tidal CO2 waveform right there, kind of the third one on that monitor. Nice square waveform, and it's at 35 millimeters of mercury, which is perfect. So again, that's our gold standard for telling us that we're in the trachea. Then you can auscultate the lungs. End-tidal CO2 first, and then auscultate. So we're going to auscultate the stomach first because if we've placed our tube into the esophagus, then we'll hear kind of bubbling sounds, and we want to make sure we auscultate the stomach first before the lungs because if we're actually in the stomach, we can remove that right away before we put too much air in there and potentially lead to vomiting of this patient. And you can auscultate the lungs after that. And if you've got kind of successful markers, you got a good end-tidal CO2 waveform and number, you got good auscultation, you can hear it entering both sides of the lungs, then obviously you're in and you can move on to the next slide. And then you can kind of just predict that, okay, perfect. Now we're in the trachea. How is our end-tidal CO2 waveform doing now? Is it kind of declining? Then that means that maybe you've got a potentially displaced tube. You're going to remove that tube and try again at another time. All right, number 7, post-intubation management. So now we've got our tube in, we've confirmed that we're in the trachea. Then put on your tube holder and make sure that it doesn't become displaced again. So you're going to look at your number on your tube, which we'll talk about how far we have to insert that tube, and just confirming that it hasn't been displaced at all. Drop more sedatives, analgesics, paralytics, whatever you're using for post-intubation management, making sure that we continuously do that for these patients because if they wake up, that's going to suck for them. And then a confirmatory chest x-ray as well when you have time to see the actual tube itself placed in the trachea above the carina. So just kind of recalling what the 7 Ps are, and again, it's kind of crucial to know those prior to clinical rotations. Not so much now, you're not going to have to regurgitate them when you're in the wet lab, but just knowing them prior to clinicals is great. Here's an intubation video for you. You can kind of see them going through these steps and kind of just confirming that, okay, we've placed the tube itself, now what do we do? And just a good video to watch prior to coming to the lab. And if all else has failed and you've been trying and nothing is getting oxygen to this patient, then we're going to move on to a cricothyroidotomy. So we can either do a needle or a surgical cric. And the needle one is more or less for the pediatric environment because that cricothyroid membrane hasn't grown large enough yet to try and allow you to cut the neck and place a tube. So we do needle cric on these patients. That is not a long-term fix. It's like breathing through a straw, which is not great, but it's at least delivering something to the patient until we can get either a trach in them or some kind of device that's going to allow them to breathe a little bit easier. And then surgical cric is the one we're going to do in our adult patients. We're going to cut the cricothyroid membrane itself. Talk more about that in the lab. You're not going to be doing it there, but we can talk about it and kind of just tell you, what are the indications for it, how do you do it, and if you do take the invasive skills lab through the Emergency Medicine Club, you will be able to practice this on cadavers. Video laryngoscopy. A lot of hospitals are moving to this now. It's easier if you can visualize the vocal cords themselves with a device. Then you can place your tube through this device, and it just makes it a lot easier. It just takes a lot of training with these things. There's a lot of pitfalls to them. It's nice to see the trachea, or to actually see the vocal opening, but sometimes it's not. It doesn't facilitate an intubation very well. So just training with the device that you're with. If you want to see more on this, we do have something called a King Vision in the lab, and we can go through that as well if you want to. Just ask. Tracheotomy, if all else again has failed and you can't get a cric on this patient for whatever reason, then you're going to move a little bit inferiorly to the actual tracheal rings, and you're going to be placing a tube through the tracheal rings instead of the cric. Same kind of procedure, but it's more surgical in means. Perfect, that's the end of our presentation. We're going to move on to Paul Fallou's second part here, where he's going to show you kind of the devices we're going to be using when you're in the wet lab. I'd like to thank my supervisor from EMS, Rick Yanko, and Tanya Weiland Ross, who's an EMS clinical educator. And for all of our volunteers that are doing these workshops, I would like to thank you very much, because we wouldn't be able to do this without you. So just a big applause to you, and we'll thank you again when we're in the actual workshop itself. Perfect. So this is the Emergency Medicine Club's Emergency Airway Management Workshop. I'm Matthew Carvey, and all this began with the EMC Board and Volunteers of August 2018 and all the way until August 2019 until now. Perfect. Thank you very much. We'll see you in the lab.
Hi, I'm Paul Falou. I'm currently a second-term student, and I'm on the EMC board. Currently the events coordinator, and we're going to review how to do intubation. This is an overall guideline. It will not make you an expert. First thing with intubation is we've already assessed the patient's airway. We've already got lines established. Patient's already receiving oxygen via the nasal cannula, and as the patient becomes sedated, we will increase that to 10 liters per minute to increase the oxygenation. Everything about airway management is preparation. So we have the bag valve mask, and we can have other people doing the bagging. You have your ET tube, and you want to have a size below and a size above what you need. You're going to check the balloon to make certain that it's still working and it doesn't have any holes and you don't develop a leak. You're going to leave the syringe attached. It just makes life easier. You have a stylet, or any number of other ways, but we'll use a stylet, and you want it to come down to just to the opening here. Fold it over so it doesn't go any farther so you don't perforate anything else. You must have suction. Intubation without suction is bad. You always check your light source, turn it on, look, make sure the light's working, and make sure you have a way to secure the tube once it's in place. For all you left-handed people, good luck. You must use, it's a right-handed procedure. Left hand's going to come in, you're going to look at the airway, you're going to sweep to the left as you collect the tongue. You're going to drive it down. In this particular blade, being a Macintosh, it's going to sit just above the epiglottis and the vallecula, and it's going to lift the epiglottis as I lift this direction towards the opposite wall. If you pull back, you break teeth, you get sued. You pull forward and lift up, and you can barely make out the airway. You can see the cords. Your right hand will take the tube and place it through. If you have difficulty, Matt's going to show what we call the Selleck maneuver. So as I'm lifting up, Matt's going to put his hand over the trachea and press posteriorly and superiorly and bring the cords in my view. And now I'm going to simply pass. Once the balloon passes the cords, you'll take about 2 more centimeters, perhaps 3. Take it out. Always control the tube. Inflate your balloon. And I always test this just to make certain that there's no leak. Take this out, always controlling the tube, and now Matt's going to attach the bag valve mask, or just the bag valve device, and we can start to ventilate as everyone else is using their hands as I maintain, and we'll begin to put the tube holder on place. And that's intubation 101. Thank you.
Thank you everyone for watching.